Hi, good evening, everyone. Thank you for joining us. Tonight, we're going to put on our last monthly webinar for 2022. It's been a wonderful number of sessions so far. And I wanted to thank Dr. Husain for help, moderating these events over the last year. I think it's gone really well. And I know that our audience has been really happy to have these monthly updates. And today we're going to review updates in small cell lung cancer, which is a little bit of a split from where we were with non-small cell lung cancer. But we're going to try to pack in some updates and advances for this condition. And Dr. Hatim, Dr. Husain, it's all yours.
Well, thank you, Dr. Lisberg. And really, it's a pleasure and honor to be here today to, have a wonderful discussion with Dr. Balmanoukian from the Angeles Clinic in Los Angeles and Dr. Aaron Lisberg from UCLA. And collectively, we're going to dissect and maybe just think through, some of the practical issues that face oncologists in practice around small cell. And so I think just to start, actually, it would be great actually to hear from you both, actually, just in your practice, how representative is small cell here in Southern California? And, just any reflections that you have about diagnosing these patients. So maybe Aaron, actually, I'll start with you if that's okay. And actually just any thoughts that you have about as you reflect on some of the small cell lung cancer patients in your practice.
Yeah, so, it's definitely the minority. I think the published number when I talk with patients is around 15% of lung cancer cases. In my practice, my number is probably around that, maybe a little higher. Certainly it's more common in the smoking population, but I actually have a number of small cell lung cancer patients that had initially had EGFR mutant disease and transformed. And so I think that that's probably a topic we'll talk about today, but I'm seeing many of those patients as well. And certainly when that occurs in the EGFR space, the disease typically gets much more aggressive, and that's a tip. Certainly that's something we have to get a histologic diagnosis for. Again, I'm sure we'll talk about it today, but that's an important kind of teaching point. In terms of diagnosis in general, it's difficult. I would say that my de novo small cell patients, I'm usually hearing about in the hospital because they're very sick and oftentimes starting therapy while they're in the hospital. Unfortunately, given the aggressive nature of the disease, there is a proportion of them that really never even get to see me in the outpatient clinic, which is also difficult. But I have seen a lot of improvement in the management with some patients that have gotten really durable benefits from immunotherapy. Again, a topic I'm sure we'll talk about today. So those, I guess, are my overarching thoughts.
Really great reflections, actually. And Dr. Balmanoukian as well, actually, be great to get your thoughts on, how prevalent is this disease in your practice? What are is there specific demographics that, kind of factor into how you think through, these patients?
Yeah, very similar to what Aaron mentioned. We're not seeing small cell as much anymore. On a yearly basis, I probably see about 2 to 3 patients with de novo diagnoses for small cell as compared to, non-small cell lung cancer. Number of people smoking, especially where our clinic is located on the west side, has dramatically decreased. Now, there are pockets in Los Angeles where you do get still a significant number of smokers, and I think the representation of small cell in those pockets is still pretty moderate. But where our clinic is, we're not necessarily seeing that much de novo diagnosis. And just like Aaron said, I am seeing a handful of patients who have converted from EGFR mutated non-small cell, lung adeno to small cell, especially when their pace of disease becomes more aggressive, and then we rebiopsy. So I've had a number of those patients as well, representative of small cell histology. When they present, I think the most frustrating fact is just basically the aggressive nature of their disease. And so I've had a handful of patients where on initial, they presented with limited stage disease, but by the time I got them to the radiation oncologist, they already had extensive stage disease because of pleural effusion or for some other reasons. And so I think just in terms of getting them through and getting them started on treatment in a quick fashion, there's just natural inherent frustrations that come with just the disease itself.
I think excellent reflections. And I will say just in my practice as well, really reflecting a lot of of what you have commented on both. I will also say actually that I remember, in learning about these diseases, we spend a lot of time focusing on, the limited stage. But in all honesty, actually, how many patients we have in the limited stage of small cell, I'd love to hear actually, have you had any patients actually who you've had to take a more localized approach for small cell treatment?
For me, in the past 10 years that I've been in this practice, I've had one patient with limited stage disease, and it was only because she presented a stage 1 disease, incidentally found lesion. It was thought to be non-small cell,
Wow.
resected, and then final path came back as small cell. So I really treated her in the adjuvant setting, and then she ended up doing well. But
Wow.
apart from that, every limited stage eventually, really just within a short period of time, converted to extensive stage.
Yeah, and I will echo, your comments here, where in my 10 years of practice as well, actually, I would say it's very similar. I remember being in a tumor board, once in fellowship with Charlie Rudin, who said that, this disease is a systemic disease, right?
Yeah.
So really I remember the discussion was taking a patient to surgery, and how to assess the stage of that patient, and really kind of thinking through, could that patient have a more progressive disease or not? And so I think the consensus of the tumor board at that time was, if a patient is borderline, whereas in non-small cell, we kind of usually look at the glass half full
Mhm.
and take patients to surgery, even under borderline circumstances, or such. I remember the result of that tumor board was in small cell, perhaps more people end up looking at the glass half empty, but I wonder if that may change. And I think that, I'm curious, both of you are experts in neoadjuvant kind of approaches and thinking through how we think about downstaging patients or thinking about this. I think, it's curious to think how some of the lessons of non-small cell, whether it be starting with upfront treatment and then actually looking at whether or not a patient can be surgically resected. I think, some of these concepts may get revisited across histology.
Yeah, I think that concept may be appropriate, especially when someone is presenting with limited stage disease and then they get concurrent chemotherapy radiation. Granted, radiation is definitive and will make surgery difficult, but if they have residual disease or they get systemic therapy and they have residual disease, but they completed their treatment, what are you going to do for those patients afterwards? So it's just a challenging disease, though.
Yeah. I may ask actually, are either of you aware of any neoadjuvant trials for small cell?
No, I
We'll
think.
have to look into this a bit. Yeah, just to see. I mean, I'm curious actually, and it's a little bit of a travesty in a way that, some of the early, like now we have so many neoadjuvant trials for non-small cell. We may only have a paucity of such type of approaches in small cell, we have so many in non-small cell that we may not have. So we'll have to kind of reapproach it, partly kind of also contingent upon the fact that, firstly, finding these patients is rare. Secondly, the aggressivity of the disease may not be really conducive to that type of strategy.
I think it's also difficult because the treatment for limited stage incorporates radiation upfront within the first or second cycles. And so when someone has that concurrent chemotherapy radiation and high dose radiation, then following up with surgery is going to be challenging for those patients. So I think any neoadjuvant approach is going to basically remove radiation from the picture. And I don't know.
Yeah.
I'm not comfortable.
Yeah. No, I think that's an excellent point. And I think it really kind of puts in perspective. Just of note, for reference sake, small cell can be radiosensitive. It is a cancer that can be amenable to radiation. And I think the concern is that the amount of radiation that may be needed as it spans, distribution of the field may make it harder to think through radiation as an option, but it can be radiosensitive. And I think that this is particularly important for palliative radiation, especially in, circumstances such as bone disease. So it's kind of an important point. May I ask actually also, Aaron had brought up a really good point here around how many of these patients are coming to you from the hospital setting versus from an ambulatory diagnostic process where a patient gets seen by a CT scan and a biopsy and such. Would you say that majority of these patients are coming to you from the hospital or coming from the ambulatory setting?
Yeah, as I mentioned, I think in my set, I'm trying to think through my recent cases. I can't think of one recent case of de novo small cell that did not come through the hospital. So I'd say they all do. I mean, obviously they don't all, but as opposed to non-small cell where it's definitely the vast majority come through the ambulatory setting. I think the small cell typically come through the hospital. And I would say in the majority of those cases, we're also starting therapy in the hospital. That's been my experience.
That's interesting. What's also curious is that as I reflect on my small cell patients a bit, the traditional teaching is like, very aggressive disease that, can just, rip through, scenarios and kind of really, cause significant tumor burden. As I think about some of my patients, though, some of them haven't had such an aggressive biology, granted more aggressive than, say, just a de novo EGFR patient. But I wonder if you think through some of your patients in this regard, were there any that kind of were less than what you expected in terms of aggressivity?
Potentially, but I guess my assessment of that would be confounded by their response to therapy. So like I can think of one patient who's responded exquisitely well to immunotherapy and it's, been on maintenance immunotherapy for a couple of years now. But his disease was very aggressive initially, and it did respond quickly, and it has been controlled. But can't really, I guess the way I would define that would be a patient who potentially I didn't start therapy for an extended period of time and didn't have rapid progression. I don't think there are many patients where I'm not starting therapy quickly, or a patient who initially got a therapy that was ineffective and went to a subsequent therapy. But during that time, in retrospect, you could look back and say, oh, they were on an ineffective therapy and they didn't have aggressive disease. No, I don't really have many patients in that setting.
And I would have to echo that as well. Majority of the patients I've seen with small cell, unfortunately, have had very aggressive disease. And majority of them, except for that one patient I noted, have had extensive stage disease. And, even as I was treating them with the initial concurrent chemotherapy, immunotherapy recently, I lost a response within, after the, fourth cycle, which was just super disappointing. One patient I saw in the clinic and then had to send him to the hospital to start treatment. But just a month ago, I met a patient who, I met him at the end of October, but he had been symptomatic since May.
Wow.
And initially when I saw him, he had a cardiac workup because he was having discomfort and pain, and everything thought that it was just pointing to the, cardiac issue, but turned out that it was actually a lung mass. And then he was eventually biopsied in July. But basically from May, scans from like April, May to October hadn't necessarily changed that much and was still limited stage in like 4 months. And but then by the time I did a brain MRI, I had a brain met. So even though systemically this disease had moved, but by the time we got him to a brain MRI, he didn't have a brain met, unfortunately.
It's interesting. I mean, sometimes I reflect upon, kind of these scenarios, and I think from what both you are saying is that perhaps kind of on treatment, some of these expectations are modifiable, and let's kind of go into that a little bit now. I wanted to kind of just also ask are you doing any biomarker testing for patients in the upfront setting at new diagnosis of small cell?
No, I mean, I do think that NGS is important, and can't think of the time that it changed my practice for a small cell patient. Up front, I don't really, I'm not certainly not waiting for any results of any testing to get started. Certainly, maybe in the resistance setting, I'm looking in some cases just with the wild chance that there may be something that would change my management, but in general, I really haven't used it too much.
I completely agree. I'm pretty aggressive with the non-small cell patients to get the results ASAP, but with small cell, exactly as Aaron said, it's usually in the refractory setting where I'm looking to see is there, something that I can target or use as a palliative approach, but otherwise I'm not necessarily chasing NGS.
Yeah. And I would agree with that. I mean, at least in my practice, actually, I don't traditionally do NGS. And the one thing I have thought about perhaps in a way is could tumor mutation burden or something like that be helpful? But in a way, kind of, it doesn't help select, against immune therapy here. And I think that would be the only consideration, is if somehow or the other there was a consideration to say, is there any patient that may not be as good of a, patient to benefit from immune therapy? I think what I've also kind of heard in some ways is, could, certain tools like, say, liquid biopsy be helpful here? I mean, looking for a somatic mutation is probably not helpful in this case. Some of the liquid biopsies are evolving to look at tumor fraction and kind of some other ways to look at chromosomal changes. Whether or not those, get used as tracking tools and such is an area of exploration. But right now I would say the liquid biopsy is probably less influential in small cell than in non-small cell. So going into that first line treatment, obviously we have multiple FDA approved therapies, carboplatin etoposide durvalumab, carboplatin etoposide atezolizumab, and also, Dr. Liskari has asked a question about the type of platinum. I may ask you both, actually, when you approach, newly diagnosed metastatic small cell lung cancer patient, how do you think through the first line? And how do you think through in terms of platinum as well as immune therapy? And actually, Dr. Balmanoukian, I'll ask you first, actually, just to take on it. Sorry.
Yeah. So I've used both. When Empower 133 was reported and atezolizumab got approval, I started using it in the frontline setting for extensive stage disease. I usually rarely use cisplatin for extensive stage disease, just given the overall limited survival benefit of patients and the toxicity of cisplatin. I may consider cisplatin though in someone who's young and who may be able to tolerate it, since as we know, patients with small cell also have significant comorbidities, and so related to smoking, possibly COPD, heart disease. And so cisplatin I may consider for someone who is younger, but typically I've been using carboplatin to limit the toxicity. Now, in terms of the immunotherapy option, so previously I was using atezolizumab. However, when Caspian reported the 3-year overall survival data, the 3-year overall survival data, as well as their brain metastasis data, really was, for me, impressive enough that I've recently been using durvalumab in combination with chemotherapy.
That's really interesting. And Dr. Lisberg, actually, what are your thoughts and comments here on that point?
My approach is very similar. I agree. I typically don't use cisplatin in the metastatic setting for the reasons mentioned. And I do essentially consider the two immune checkpoint inhibitors interchangeable, but I agree that 3-year data was convincing. And I guess the most recent patient I started, I also used durvalumab, so it's a similar approach.
Perfect. Sounds good. And may I actually also ask you kind of what, when you speak with patients in that first line and they ask you about, how am I going to do with this treatment, or kind of what are the expectations of clinical benefit? How do you approach that conversation with them? Like, what do you mention in terms of, what to expect?
Yeah, so I mean, obviously those discussions are always complicated, and I tailor them to the specific patients. Some patients want to know numbers and some patients want to know more generalities. The overarching themes that I use with small cell are probably the same that we all use. I typically say, I think what's been mentioned already tonight is, it's a very responsive disease to systemic therapy. We know it's a chemo-responsive disease, and the addition of immunotherapy has improved our benefit over time. That said, since given its responsiveness and also its aggressiveness, it oftentimes overcomes therapy in a shorter period of time. I do emphasize the one advance, in my opinion, not my opinion, but in general, the one advance recently, which is the addition of immunotherapy, which I think is exciting. The devastating diagnosis, but I think we can point to a subset of patients that are doing really well. I mean, I'm thinking of a patient who's in his late 80s right now, who has been on, like I said, maintenance immunotherapy for, I think, 2 or 3 years now, living a totally normal life and had just as aggressive disease as everybody else, started therapy in the hospital. So that is certainly not the norm, but it is something that is new in the field, and something that I'll talk about with patients as well. So that's how I generally discuss it. And, the other thing to talk about, I don't like to say this right up front, but as we're kind of moving through the therapy, maybe if there's oligo progression or different things. Unfortunately, there's really not great options after the front line, which makes things pretty difficult. Obviously, it's an area we need to be investigating on trials, and we do have some in that space, but that's kind of like the overall picture in terms of how I paint it to my patients.
Yeah, it's super helpful. And I think, some of these more practical considerations about, what are some good tips to really make sure we don't forget to mention, in these visits with patients, I think is critical. Dr. Balmanoukian, any thoughts you have in that regard?
Yeah, usually I think as oncologists, we're always a glass half full kind of, we always have a glass half full approach. And, when I get a patient with newly diagnosed non-small cell lung cancer, I tend to always focus on, okay, this is the treatment we're going to do. And I'm never talking about actual, life expectancy or outcomes. Small cell is the one place though where I want to paint a realistic picture up front because of the aggressive nature of the disease. And so when I have a patient come in with extensive stage disease, I have the exact same conversation that Erin mentioned, basically just noting that this is a cancer that does respond to chemotherapy, but there is a high chance that it's going to essentially figure out a way to outsmart the treatment that we're giving. Having said that, immunotherapy is a novel approach, and there are patients who respond to immunotherapy and may respond very well for a number of, well, for a while. Hopefully for years, like Erin's case. I have yet to experience that, but I'm always hopeful. So I do have those conversations in regards to the new approach, the addition of immunotherapy, but I try to be also just guide them in a direction so that they don't become disappointed or frustrated when within a couple of months they may potentially lose that response.
Really important. No, and I think that's true. And I also think actually that, just setting the expectation about, after, I remember, someone had mentioned that in oncology, you see the highest highs and the lowest lows. I think small cell is one of these things where, you can really briskly see a response, but then that, short time to progression perhaps, or kind of a shorter time to progression, I think is concerning, for a lot of people. And I think reflects that roller coaster a bit. I think one other point actually that I think is important to highlight for patients is just some of these tails of the curve. And I think the 3-year data on the Caspian study, I think is impressive in that regard. So again, just to highlight that at 36 months, the OS rate was about 17.6% with the treatment group with durvalumab compared to 5.8%. And again, as in the first line in non-small cell, at least my particular opinion in the matter is that one of the battleground for which is the right first line therapy for, for patients may be what we see on these tails of the curve to really talk about, that meaningful long-term benefit. So, obviously, as we see more data in longer survival, it'll be curious to see how some of these tails persist or not, and we'll have to think that through. So actually super interesting, and I think very relevant here. I think now reflecting upon the fact that patients in many cases inevitably have a progression, I may ask actually, what is your first consideration about a second line therapy? Which therapy do you think about in that setting? What are some of the experiences that you've had in the second line for small cell? And maybe Dr. Lisberg, I'll ask you first in that regard.
Sure. Yeah, like I mentioned, unfortunately, my experience in the second line setting hasn't been very good. I've tried different options. I've tried lurbinectedin, I've tried topotecan, tried temozolomide, and I don't know. I don't have a favorite because I just really haven't seen great benefit. We do have some trials in the space that I'm excited about. I think it's an area of significant unmet need. So that's where I've been thinking. But a lot of these patients aren't trial candidates, and the disease is really aggressive and can't move in that direction. So really don't have a favorite. If you had to pin me down, I probably would go with topotecan or lurbinectedin. But again, the patients I've treated with those agents honestly haven't done exceedingly well. So it's a really difficult spot.
Yeah. And Dr. Balmanoukian, what has your experience been in the second line?
Yeah, it's honestly been incredibly frustrating. I had luck re-challenging a few patients with carboplatin and etoposide because it had been greater than 6 months. It had been, 7 to 8 months when they had their recurrence. This specifically, I'm thinking about two patients who had EGFR mutated lung that switched to small cell, transformed to small cell, and so I had luck re-challenging someone with carboetoposide and actually got about a year and a half from that. Um, but then after progression, after the second retreatment, I actually tried giving Taxol and it just didn't work. The other patients where I tried to get second line, I tried using immunotherapy back in the day, didn't do anything. And then the other ones have just never even made it to second line because they just progress so rapidly.
Yeah.
But if I were in a normal setting, I think I would try lurbinectedin next. And I think that would be my go-to. But I've just really, it's just has been very challenging.
It's interesting as I reflect on the lurbinectedin data, it hasn't necessarily been totally reflective of my practice. Kind of when we think about what was the ORR that led to the FDA approval of that medicine, the ORR was 35%. The duration of response 5.3 months, and that was based on an earlier study. The confirmatory study was known as the Atlantis study, and that actually included about 630 patients with small cell lung cancer. It was across 17 sites, and some other key points with this trial is that the lurbinectedin dose was a little bit lower. It was 2 milligrams per meter squared, plus doxorubicin. So a little bit of a different regimen than what the FDA approval is, which is lurbinectedin by itself. The median overall survival was 8.6 months compared to 7.6 months in the control arm. And the control arm, was investigator's choice chemotherapy. The PFS actually was in the order of about 4 months, and that was consistent across the two groups. In this study, too, the response rate with the lurbinectedin combination was about 31.6%, and in the topotecan group, it was 29.7%. So it's interesting. I mean, these medicines, at least on paper, appear to have, not insignificant response rates, but really that duration and also, progression-free survival, I think is limited. But particularly for those patients actually who need a response or kind of such, I think it was surprising to me actually to see that response rate with topotecan about 29% and lurbinectedin 31%, roughly the same. I think it is kind of interesting to see that through and think that through.
I think that has been generally the thought also is that data was, available and lurbinectedin was approved, but then just sort of polling all the oncologists who have used the lurbinectedin in the second line setting, clinically, the responses have not matched what was reported. And so most of the providers have not really seen the responses that would have been predicted with a 30% response rate.
Yeah, and that's my experience as well. And I think perhaps reflects Aaron's points earlier, actually, that he hasn't really seen, say, that meaningful benefit. But I don't want to put words in your mouth, Aaron. Actually, is that kind of what you were implying as well?
Yeah, that's right.
Yeah. Okay.
But I think, Aaron, from what you mentioned, which was a great point, is that a lot of these trials are, selecting for the best candidates for the studies. And in the real world, when you're seeing patients with small cell, there's so many other comorbidities. So it's possible that, having other comorbidities and, having the trials not be reflective of real world patients is what's leading to not seeing the clinical benefit in the real world.
I think that's probably very true.
So I may also ask, actually, back, so ipilimumab and nivolumab had gotten an NCCN designation in this disease. I actually used it a fair amount, actually, for patients. And I was actually quite impressed with some of the responses that I saw. I did see some people who had actually responses in the brain. What were your reflections on CTLA-4 and PD-1, ipilimumab and nivolumab? Did you have a lot of use of that combination in this disease?
So we had a clinical trial with a CTLA-4 and anti-PD-L1 with small cell. And unfortunately, we didn't see any responses in that clinical trial. It was sort of like a basket trial looking at multiple diseases, including small cell. So, and then off trial, I used Ipi and Nivo in a second line setting. And again, just didn't see any response either there.
So
I'm still optimistic that I'm going to get a response. I'm going to get a patient do well at some point.
yeah, my experience has been similar. I haven't seen benefit, but I mean, the number of patients we're talking about here is very limited.
Just to reflect upon some of that data, just from the numerical standpoint. So again, there was a phase 1/2 trial of nivolumab plus or minus ipilimumab called the Checkmate 032 study. And that had about 96 patients with nivolumab and ipilimumab. And the response rate with that combination was 21.9% versus 11% with nivolumab alone. And in terms of follow-up for long-term OS, the OS median was 5.7 months versus 4.7 months with the nivolumab alone. So, there seemed to be some response, but it didn't seem to be a very durable response on this regimen. But I think as a whole, it was included in NCCN guidelines, and then it was subsequently removed. So that's one point. Also to comment about the durva-tremi. So basically, as part of the Caspian study, there was an arm of durva-tremi plus chemo as well, and that actually also did not meet its endpoints in that regard. So now what I wanted to do was, we kind of dissected out some of the available options in the first line. We dissected some options in the second line, meaning lurbinectedin, topotecan. I wanted to talk a little bit about what some other approaches are. And, Erin had mentioned perhaps some clinical trials that you have. I wanted to also, prior to doing that, reflect upon what your threshold is or use for going beyond the medicines that we spoke about. Like Dr. Balmanoukian, I may ask you, besides lurbinectedin, topotecan, has there been any other regimens that you've tried in small cell? And what would one, consider if there was a patient who was still eligible to get treatment who, just wasn't responding or kind of needed something more?
Yeah, I think there are, I've used the immunotherapy combinations like Ipi-Nivo, as I mentioned. But I think otherwise, as Erin mentioned, Temodar is something that I would go to in that setting as well. So I would use Temodar, given that there's some data, especially if they have brain metastasis as well. Irinotecan is something that has been also used. And so I think I can, if a patient is still clinically doing okay after multiple lines of therapy, then that's something to consider. And of course, clinical trials.
No, I think that's excellent. And I'm curious to see what you would also think about for this reflection. So, there was a trial that was published in, I think it was 2020 or so, around that time, of a PARP inhibitor, olaparib plus temozolomide. It was, brought forward by Anna Farago of MGH at the time. What was curious about that trial is that they reported a response rate of 41%, PFS of 4.2 months, and an OS of 8.5 months. It'd be curious to see, what is your threshold to consider somewhat of like a off-label use or kind of consideration in this setting? Is that something that you would consider?
I would. I'm not necessarily sure if I would add a PARP inhibitor. I would just do the Temodar in this setting. I think it depends. I'd give it some thought. I mean, that data is compelling. I don't know why it didn't necessarily gain traction, but given that we don't really necessarily have an FDA approval, I think I would still just resort to just Temodar versus adding toxicity with another agent.
So
And Dr. Mark, I may ask you as well, your thoughts on this question too.
yeah, and interestingly, that is one of the trials that we've seen some success with at UCLA. So the trial's looking at niraparib, temozolomide, and atezolizumab. both in patients as maintenance therapy with the atezolizumab or in patients that have had a response and then relapsed. I think we published some data at ASCO in a poster, but we've seen benefit and it's being expanded into more patients. So certainly leveraging that PARP inhibitor data that you discussed and potentially synergy between some of these agents. Certainly when you start adding in multiple agents, the toxicity is the question, but it's been a pretty well tolerated approach. Again, not every patient's eligible for a clinical trial, but in this setting where there really aren't great options, we've seen some benefit, which has been pretty exciting.
Actually, that's really curious. Actually, I think it's fascinating to hear about that, partly because unfortunately, kind of our armamentarium for effective agents seems quite more limited than in non-small cell, right? And so really kind of, reflecting upon that, I think it is interesting actually, because as lung cancer oncologists here, the use of PARP inhibitors is probably more limited. I may actually ask Dr. Lisberg, kind of in your experience, actually using perhaps in prostate cancer or in breast cancer, have you had any experiences using PARP inhibitors in small cell? And Dr. Lisberg may be on mute.
Yeah,
but...
no, I'm here.
Okay.
I have used PARP inhibitors off-label for patients who have DNA repair mutation changes noted on NGS, but I think on one patient, but did not have much of a response.
It's curious actually, Dr. Lisberg, because I know you see a lot of prostate cancer as well. Do you, in patients who transform in prostate cancer to small cell, firstly, are you aware of any DNA damage repair, mechanism there? And is there selection for PARP inhibitors for these patients at all? Is there any kind of discussions in that space that you've heard of? And I'll repeat that question actually, just so you can hear it. What that is, for prostate, is there anything that you've heard about in terms of prostate conversion to small cell on top of androgen, deprivation therapy that may be important to think through with the PARP inhibitor in that space? Oh, I think, I think we can't hear you.
Sorry, who's the question directed to?
Oh, I was going to ask you actually, just because, I know
right.
you see a lot of, or you see prostate as well.
Yeah. I think there's definitely some, there's definitely some activity that we see with PARP inhibitors in prostate cancer, but not all DNA repair mutation patients who harbor different DNA repair mutations actually do the same. Patients with ATM mutations, for example, don't necessarily respond as well as some of the other DNA repair mutations that are seen, such as BRCA1 or BRCA2. So there's some heterogeneity there, even though there is FDA approval across various DNA repair mutations. So I do think there's some variability there. And I don't think that has been, at least from my understanding, really well understood as it's crossed over to other disease types.
In the patients with prostate who switched to small cell, have that conversion to small cell, is there anything that you're aware of PARP inhibitors being, investigated in that space or kind of considered?
I mean, I think certainly that's an area where platinum-based interventions are used, and so certainly, looking at PARP inhibitors would be an opportunity. But that unfortunately, I think those patients tend to have very aggressive disease, very much like small cell lung cancer. I think investigating that, I'm not aware of trials looking at that, but I would imagine performing a trial like that could be logistically a bit challenging.
And I think that's a great segue actually to go into, perhaps our experience with EGFR converting to small cell. I think it's actually, a little bit of a curious thing that, some other settings, actually, there's just not enough patients that other groups may have to actually even talk about this concept so much. But I think, as we each have mentioned that we may have patients who, kind of have had this, we've actually chronicled, many of our patients in this way. And it's curious, actually, I feel like it's probably underrepresented, in our practices. I may ask this, actually, this is an interesting point, but how often are you guys able to get a tissue biopsy post-progression on an EGFR inhibitor? And I mean, are you getting this routinely to capture and understand these patients, or is it something where it's kind of like when available, or kind of like one-off scenarios where the biopsies are able to be obtained? Actually, Dr. Lisberg, I may ask you first, actually, this question.
Yeah. So, yeah, obviously on progression, I think it's important to reprofile these EGFR patients. I'll have a discussion with patients, but in the absence of like clinical features to suggest small cell transformation, I will offer liquid biopsy typically. And as would be expected, I would say that's the option that most patients pursue. However, when, the clinical characteristics have significantly changed and the disease has become much more aggressive, I become very insistent on getting the tissue biopsy. And I'm thinking of multiple cases recently where that's been the clinical suspicion and the biopsy has proven that. So when I guess what I'm saying is when I felt like it's needed to be done, I've been able to get a tissue biopsy and make the diagnosis. Really
super interesting. And Dr. Balmanoukian, your thoughts on that question?
Yeah, I typically discuss a repeat biopsy with a patient, especially, when they do progress. So especially if it's a site that's easily amenable to a biopsy, I would say all patients are completely open to doing it. If it's, if their disease is very challenging to get a biopsy, I'm not going to refer them to a surgical biopsy, but that's when I'll do a liquid biopsy. But if there is a lesion that is amenable to a biopsy, I would definitely refer them.
Mm-hmm. No, I think it's really curious. And I think Dr. Lisberg, I kind of reflected a little bit on what you had said too, is that, there's certain clinical features that really kind of make one think about, small cell more than others. Perhaps there's a little bit of bias though in that thinking about how to prioritize the tissue biopsy, versus not. And so it is curious, but I will say I probably, also similar to you in that regard, use some of those clinical features to help that selection process about tissue versus plasma and how I prioritize the two. So now actually going into this experience with the EGFR cohort, may I ask actually, so if you have an EGFR patient who converts to small cell, are you, firstly, which chemotherapy are you doing? Are you integrating immunotherapy at all into the circumstance? And how are you approaching how to treat those patients? And actually, Dr. Lisberg, maybe I'll ask you first that.
Sure. Yeah, no, that's a difficult question that I've wrestled with for a while. Initially, obviously, we have a lot of data to support the idea that EGFR-driven disease does not respond to immunotherapy well, and also that there potentially is more toxicity. However, again, consistent with all the things we've talked about during the past 5 minutes, hopefully we'll actually leave the room. Hold on a second. Can you please leave? Okay, cool. Sorry about that. Consistent with everything we've been discussing and given the aggressive nature, I've changed my thinking and I am incorporating immunotherapy when I have histologic diagnosis of small cell transformation. And I'm typically treating with this same approach that I would use for my de novo small cell. I'm using a platinum-based agent, etoposide, and then atezo, or more recently durva. And I just feel like giving them the best chance to control the disease is important. And yeah, I have acquiesced and given immunotherapy, and I have seen responses. Of course, I don't know if it's from the chemotherapy aspect or from the immunotherapy, but I just don't think withholding immunotherapy in that setting, I don't think we have enough data to do that. And the disease is moving so quickly, and we have such a high chance of losing complete control. That's how I've been practicing.
That's really, really interesting to hear that viewpoint. Dr. Balmanoukian, kind of your experience there. Actually, do you go to a full small cell regimen inclusive of the immune therapy?
So I've done both. Just recently I had a patient who had that conversion, and initially I treated her with chemotherapy and immunotherapy, and then she did okay, but then while on immunotherapy, she had progression. We went through another route of, I think we did a liquid biopsy at that point. Liquid biopsy came back with her original EGFR mutation. And so in order to get her back on systemic therapy, I actually stopped the immunotherapy, gave a little washout, and she had developed brain metastasis along the way. She had never had brain metastasis. Got her back on osimertinib, and then carboplatin and etoposide. Her brain mets completely resolved, and then she continued with carboplatin and etoposide at that point. So I've done both depending on the patient situation.
So just so I make sure I understood, so when you restarted the osimertinib, the brain mets resolved.
Yeah.
Okay. It's curious, actually. I think it's a fascinating point, and as Dr. Lisberg says, we don't have a lot of structured data in this space. At least my practice pattern, I would say, is one where I do the chemo etoposide, but I continue the osimertinib for the protection in the brain, at that point. I think that the data in this, so there was a trial or a retrospective cohort assembled by Alicia Sequest, where, tried to look across multiple sites to aggregate cases of this conversion of EGFR to small cell. And, what was shown is, firstly, a lot of details about the genomics there. P53 and RB loss are very important components, concomitant mutations with the EGFR, to signal this event. And then second, kind of another point was that immune therapy didn't seem to really work that well. And granted, this was at a time when the immune therapy was given, in many of the cases, were given as second line, either single agent. There was actually at that time the approval or kind of indications for nivolumab and ipilimumab as well. And so there was like some data about those types of regimens, which didn't show a high response rate. In fact, actually, the agents that seemed to be the most influential in terms of causing a response were, platinum based, but also second line taxanes. And this, I thought this was kind of interesting, is in that paper by Alicia Sequest, and the first author is Nicholas Marco. And, basically what it showed is paclitaxel had like a very high response rate here. And in fact, I actually had a few patients who were treated in this way. So platinum, etoposide, and then actually at progression in that way, paclitaxel. And in fact, actually the tumors really shrunk, quite dramatically with that taxane. So I think as a whole, it definitely is interesting, perhaps signals that the biology of these EGFR small cell conversions are obviously different than the de novo small cell. And while some of the genomic events, particularly P53 and RB1 loss, may be common, as a pathognomonic feature of these two types of syndromes and circumstances, really kind of the responsiveness to chemo may be different too. Unfortunately, though, in the EGFR cohort, it seems like the duration of response is not as long too. So I think kind of, further considerations there. I think in the last several minutes, actually, there are a few compounds that I'd like to, just kind of dissect with you guys to think through, and other trials that you have for small cell. I may actually ask Dr. Balmanoukian, do you have any studies for small cell at the Angeles Clinic right now?
We don't have anything specific for small cell. Our trials predominantly are just phase 1 immunotherapy, so novel immunotherapy agents that will look into various disease types. So that can include small cell, but we don't have anything specific for small cell at this time.
Okay. And Dr. Lisberg, besides the niraparib study that you mentioned, any other trials or anything like that that you have for small cell?
Yeah, so an area that we've been really involved with that has small cell opening right now, we've been really excited about some of the benefit that's been seen is the TROP2 ADC from Daiichi, Dato-DXd. So they initially had a 15 patient cohort that opened probably about 9 months ago. And there's no published data, and I don't know anything about the efficacy was seen, but they did open additional 25 slots in the small cell cohort about 2 months ago. So that's somewhere we've been looking to put our patients. We put both EGFR transformed to small cell patients as well as our frontline, de novo small cell patients in that approach, and potentially could be an interesting agent in the space moving forward.
No, really interesting. I think the ADCs in small cell particularly are important to really think through. So one of the first ADCs was the DLL3 ADC. And unfortunately, while there were responses seen, there was toxicity with serosal edema and serosal effusions and such like that. And so be curious to see how some of these other antigen-associated ADCs, such as TROP2, may be indicated or, kind of have benefit. So another last one, just in the final moments to kind of mention is the DLL3 target is still an active area of interest, even though the ADC, antibody-drug conjugate, didn't seem to meet its, endpoints that were being looked at and also had toxicity. There are other agents that are being considered. So one of the ones that was presented recently at ASCO was the DLL3 BiTE technology. So basically, this is a molecule that binds DLL3 and CD3 on T cells, and as such, actually is able to lead to a T cell dependent killing of the tumor. So the medicine, there's a medicine by Amgen known as AMG 757. And, there was data presented where in some of the earlier analysis, there was a partial response of about 14% that was seen. Some of the updated analyses, that we're seeing over here, the confirmed responses across all the dose levels that were being explored were 8 of 60 patients, so that's about 13%. And at higher doses, the dose level 10, 100 milligrams, it was 63%, 5 out of 8. The median time to response was 1.7 months. Duration of response was greater than 6 months in 71% of patients with any PRs, and the disease control rate was 43%. So that's with any shrinkage being in about 38%. So interestingly, with this type of technology that activates T cells, it's important to know about some of the side effects. So one of the things that was commented about this medicine is that there could be some cytokine release syndrome in 42% of patients. It was grade 2 in 11% patients. It was generally reversible, managed with supportive care or corticosteroids or IL-6, anti-IL-6 receptor antibodies. It didn't lead to any treatment discontinuations. So as a whole, some new novel molecules being explored here, whether they be more immunological or ADC oriented. And I think it is an interesting, consideration. Are you aware of any other kind of interesting molecules being explored in small cell?
I am not.
And I think it's actually, just goes to show that because of both, the fact actually that this is a very difficult cancer and actually meeting its endpoints, as the recent data with TIGIT has demonstrated, where, unfortunately at this year's ASCO, one of the biggest, somewhat disappointments is that the first line data with TIGIT in combination with the chemo did not appear to improve outcomes compared to chemotherapy. And I think that, if that is only a small cell specific effect, or if it's a larger effect is still unknown, but I think, there's some considerations that, a lot of the trials are still ongoing with non-small cell that, perhaps kind of maybe this is histology contingent. And that was one of the considerations in the discussion that was made at that ASCO meeting. So TIGIT, unfortunately, we'll have to see how some of the other molecules are also being explored. Dr. Lisberg, are you aware of any other studies that are being done here?
No, again, I think it just speaks to the difficulty of running trials in this space with this patient population, and unfortunately, getting control of the disease. Yeah, I don't aware of anything really exciting at this time.
Well, looking forward actually to some of these other molecules. Thank you for sharing your experiences both with the PARP inhibitors as well as the TROP ADC, and also some of these emerging molecules, particularly the BiTE technologies that bind the CD3 as well as the DLL3. And we'll see how some of those approaches kind of unfold. So with that, actually, I think we're going to finish our discussion today. Thank you so much, Dr. Lisberg and Dr. Balmanoukian, for your participation today and kind of your insights into this disease, and as always, all of the topics that we have discussed. And Dr. Liskari, I'll turn it over to you for closing comments.
Thank you, everyone. Thank you guys so much for joining us. And we have recorded this session for our members to have access to. And yeah, this was really a wonderful discussion. Very challenging disease. Hopefully, more clinical trials can be dedicated to it, because obviously that's where we'll hopefully be able to find new breakthroughs. So on that note, we'll see you next year. We're excited to relaunch our monthly series starting in January of 2023. So everyone have a wonderful holiday season. Thank you, Dr. Balmanoukian and Dr. Lisberg, for joining us. Dr. Husain, as always, thank you guys.
Thank you so much. Yeah.
Bye-bye.
And happy Thanksgiving to all.
Happy,
Bye.
absolutely. Bye-bye, everyone.
Holidays. Yep. Bye-bye.